All right. Thank you very much for your patience while we wait for the few remaining participants to join. And good afternoon, everyone. My name is Ken Gillan, a Senior Business Solutions Consultant with Spatial Vision, and it is my genuine pleasure to welcome you all for today's presentation and demonstration of the Women's Health Atlas platform. This week, we heard from the Secretary General of the United Nations Human Rights Council, who delivered an important speech titled "The Highest Aspiration, a Call to Action for Human Rights." And I'll refer to a short excerpt which stated that human rights are our ultimate tool to help societies grow in freedom, to ensure equality for women and girls, to advance sustainable development, to prevent conflict and reduce human suffering. Now, I think we can all agree that each of these drivers informing the 17 Global Sustainable Development Goals are among the most pressing issues in today's times. But I think we can also agree that we cannot simply afford to wait for a single global response to remedy them. The issues that we face in any one neighborhood, in any city or region, will of course differ when compared with another, because the resources, the infrastructure, demographics are all different and unique. And so there is no one-size-fits-all solution, and we need to think, plan, and act with a local mindset. I think we can also agree that equality for women cannot remain an aspiration. It must become a societal norm. To achieve it, we each need to collectively contribute to and support, raise awareness, educate, and invest in change incrementally and from the ground up. And that's where the efforts of non-for-profit organisations like Women's Health Victoria are making a significant and meaningful impact. So it is therefore my esteemed pleasure to introduce our speakers now, who will demonstrate how the Atlas is being leveraged and to showcase some of the important initiatives being led by Women's Health for women's health. Representing Women's Health Victoria, we have Mischa Barr, Policy and Health Promotion Manager, Jenny Ward, Information Officer, and Django Love, Senior Policy and Health Promotion Officer, with support from Spatial Vision's Tom Hollands, a location analyst and consultant. So for today's agenda, we will address each of the following key themes, providing some context around the platform's development, design, how it's being used, and importantly, the impact that it's making. We'll also hear about some of the key initiatives Women's Health have in development to further extend the utility of the Atlas, as well as delivery of some essential services to key stakeholders, and most importantly, the community. So before we get started, I'd like to invite you all to use the chat facility to raise questions at any stage throughout. We'll arrange to capture and consolidate these and respond following the presentation. We'll also invite you to participate in a short survey that will be made available to participants following the event. So without further ado, please let me welcome and hand over to our first presenter, Mischa Barr.
Thanks, Ken. So I'm Mischa. I'm the Policy and Health Promotion Manager at Women's Health Victoria. My role includes overseeing all of our policy, advocacy, research and training work in women's health and gender equality. So I'd like to start by just giving you a little bit of background about who Women's Health Victoria is. So as you can see there, we're a statewide women's health promotion, advocacy and support service. In 2019, we celebrated our 25th anniversary as champions for women. Our vision is women living well, healthy, empowered and equal. We advocate for and build system capacity for a gendered approach to health. And we have 5 priority areas: sexual and reproductive health, prevention of violence against women, women and cancer, mental health and body image, and women's equality. We also deliver a range of direct services that respond to those different priority areas. And you can see a selection of those here with the Women's Health Atlas down there in the right-hand bottom corner. We're also there are many other women's health services around Victoria. We're part of a network of women's health services. There are 5 metropolitan women's health services, 5 rural services, and 2 other statewide women's health services, the Multicultural Centre for Women's Health and Women with Disabilities Victoria. And most of those women's health services share those same women's health priority areas that I outlined earlier. And we're funded by the Department of Health and Human Services under the Victorian Women's Health Program. So why women's health? So disparities in health outcomes are determined not simply by biology, but also by the social, cultural and economic factors that influence people's lives. Evidence shows that gender-based inequalities are both the underlying cause of poor health outcomes for women and create barriers to achieving improvements in women's health across the lifespan. So structural barriers such as poverty, childcare responsibilities, single parenthood, income inequality, experiences of family violence and sexual assault, underrepresentation of women in decision-making roles, the underfunding of women-specific programs and services, to name a few, are some of the factors that disproportionately impact women's health outcomes. And as many of you would know, for Australian women aged 18 to 44 years, intimate partner violence is the leading contributor to disability, illness and death. And we've been starkly reminded of that this week. So health policy and planning needs to consider the way that gendered norms, practices and structures perpetuate inequality and impact the way women and men encounter or interact with the health system. So in taking a gendered approach to health planning and service delivery, this can make visible the different needs and life experiences of men and women. And I should note here that data on non-binary and gender diverse people is generally lacking and is not represented in the atlas. A gendered approach to health planning also makes visible differences in health outcomes for women and men. It can illustrate how gendered norms, practices and structures contribute to differences in health outcomes and how health policies could be strengthened to reduce those gender inequalities. And it also demonstrates how prevention, diagnosis and treatment programs could be reoriented to meet the different needs of men and women. It's also important to note that gender-based discrimination interacts with other lived experiences of inequality. Social and structural inequalities such as race, class, sexuality, disability and residency status can increase women's risk of experiencing poor health outcomes. One of the challenges we have in the atlas is the lack of data that's disaggregated by more than one demographic characteristic. So while we can access data that's disaggregated by gender or by disability or by Aboriginality, we can't disaggregate it by all 3 of those characteristics. But overall, by addressing the social determinants of health, including gender inequality, we can create a more cost-effective healthcare system that reduces disparities in outcomes for disadvantaged groups and delivers better outcomes for all Victorians. So where does the atlas fit in all of this? So to be able to apply the gender lens to our work that I've just outlined and improve women's health outcomes, we need access to up-to-date, reliable, sex-specific data. Sex disaggregated data is also critical for monitoring and evaluating our programs and interventions, so we can see if they're making a difference for women. When we developed the atlas back in 2015, the state of play was that local women's health services were trying to obtain the kinds of data that they needed to be informing health area planning in their regions, so that they could benchmark the work that they were doing. However, potentially relevant statistics were scattered across a multitude of data suppliers and platforms. Women's health services around the state were going to great lengths to develop and maintain their own printed data books and fact sheets. This created a huge burden of data acquisition, collation, design and formatting, and the cost of printing, only to have them go out of date really as soon as they were printed. So, working with the Department of Health and Human Services, we were funded to deliver a pilot and received funding initially for 4 months in 2015 to create the atlas. And the overall purpose of that was to ensure that there was up-to-date local data that could highlight gender inequalities, demonstrate the need for a gendered approach to health, and provide evidence to monitor trends over time. And in addition to working with the Department of Health and Human Services, we also recruited a stakeholder advisory group, which was made up predominantly of women's health services and representatives from Family Planning Victoria. And the role of that advisory group in the development of the atlas was really critical. in particular for translating those user needs into the design brief, identifying our key priority areas and the data sets within those priority areas that we wanted to include on the atlas, and in testing and refining the platform. It's worth noting at this point that although maps have become such a feature of the atlas, they weren't actually originally included in the design concept. And Tom, I think, will talk a little bit about that. And of course, we have also worked with our technology partner, Spatial Vision. And we chose Spatial Vision because of their demonstrated experience working with the not-for-profit sector. The fact that they'd already prepared some concept designs for a similar interactive atlas for one of the regional women's health services. They were based in Victoria. They shared our values and they proposed a solution that fit within our budget. So the atlas has come a long way since 2015. We started back then with 4 priority health areas and relatively basic functionality. But now we have 57 health and socioeconomic indicators across 6 priority health areas, some of which have up to 6 years of data. And that's evolved over time in response to user needs and feedback, as well as funding availability. Our data sets are now sourced from many different agencies. I think there are 10, which are mapped across the atlas. And this includes many data sets that are obtained by custom request and aren't readily available elsewhere by LGA and sex, including on things like long-acting reversible contraception, hospitalisation for self-harm, intimate partner violence, breast and bowel screening, and teenage birth. These are all customised data sets that we've included on the atlas. So I'm going to pass over now to Jenny Ward, who's going to give you a live demonstration of the atlas. Thanks, Jen.
Thanks, Mischa. Now we're going to attempt to go across to different screens. So if someone could let us know in the chat if you confirm whether you move from the slides across to another screen that shows the homepage of the atlas. So I'm going to share that now. If somebody could just confirm that you can see that. Have a look up here. Hopefully it's okay. Right, we've got a few people responding. Let's just have a look there. Yes, you can see it. Fantastic. I'll just minimise that. Off we go. I will assume no prior knowledge. So to navigate the atlas, first of all, we start by looking at the 6 priority health areas. For today, I'm going to choose violence against women. The next step is to look at the available indicators and choose one of them. I'm going to focus on intimate partner violence. This then opens the various measures available, and I'm going to choose the number of notifications for this demo. The default view, it brings up the statewide map showing the female situation for the latest time period that we have mapped. So some very important controls are over here. So it's showing the female map, if you can see that. We can use this as a toggle. If there's a male stat available, clicking on that will open the male map. The next set of controls control the zoom. At the moment, we're on the state view. We can also choose all of metro at the touch of a button. We can also click on region, which opens a drop-down list, which we'll do shortly. For now, I'll go back to state view and female. Down here on the right-hand lower corner, we have the legend, which shows you what number of value ranges are represented by the colours on the map. In the atlas, we use 2 colour ranges. This one is a traffic light, which means that things that are green are progressing towards something we'd like to see, which is in this case lower incidence of intimate partner violence. LGAs that are red have a higher incidence. Now, when you use the atlas, after about 3 minutes, the survey will pop up, and it has done so here. So I'm just going to close that for now, but just when you're using the atlas, you have the option to give feedback. And if you want to do it at the end, you can actually go right up to the terms of use, right up the top here, and there is the feedback link there. Over to the left-hand side, we've got very important text fields that provide context for the data. So there's a description of the data set and the statewide position, a brief gender analysis, why is this important for women? Then the next thing describes the indicator, and it's very important to describe what is it measuring. Are there any limitations on that, such as the age, or certain things are included or not included? And finally, the source of the statistics. So you can trust the information and where it comes from. Below the map, we have the bar chart. This shows 1 bar for every local government area represented in the map. Now, what you can do here is these buttons, radio buttons, allow you to turn these on or off. So the female bars, if I click on that, they turn off or on again. Male, I can turn them off or on again. And where the order they sort in, at the moment they're sorted by female, and that's because up the top we've got the female map selected. If we wanted to sort in order of male, we'd have to have the male map selected. I omitted the time slider, which I should have mentioned. At the moment it's showing the latest year. We can slide through years by just moving along. As you can see, the map will change accordingly. We can instantly go back in time or forward in time, and all of the information changes accordingly. So that makes it very quick to view those things. Okay. The next thing we're going to do is, let's say we want more information at local government area level. It's possible to mouse over these on the map and you'll see the names appearing. You can also mouse over the bars in the chart. Now, curiosity might lead us to say, what's the highest? Oh, click on it and it reveals that it's Casey, and it also highlights it on the map here. It's very small. So let's zoom in on that and see some more detail. So I'm going to choose region. This opens the regions that align with the Women's Health Services, as mentioned earlier, and we're going to pick Metro South East. It now zooms in closer and we can click on Casey and it highlights it again. Notice at this view that the labels have now turned on for the LGAs, which can be very handy if you're doing presentations and you need to get the information. It's possible to get outputs from the atlas. If you wanted to download this particular map, any particular map, you can see there's a print icon here. This downloads it to PDF. It creates a 2-page output with the map on the first page, and then you'll have the text on the second page. So it does all the formatting for you, no more to do, which is good. Now, hopefully I won't lose anything here. Hopefully everyone can still see that. Now what we're going to do is look at the View More window. You'll see when you have an LGA highlighted that this window also pops up. You can click on here and it opens up a graph showing trends for easy visualisation. It compares the female to the female state average and the male to the male state average, everything there. We're going to go into the fact sheet in a minute. View Less closes that window again. We're now going to, let's say we want a different measure altogether. We don't have to go back home. We can use the change measure here. It's possible to choose anything, but I'm going to stick with intimate partner violence, and now I'm going to look at the rate per 10,000. What this does is convert the count into something that's based on the population, and this then enables benchmarking against other LGAs. Given that Casey is one of the fastest growing suburbs, it might be misleading to base everything on the count of intimate partner violence. When we look at the rate per 10,000, you'll see from the bars that they're a lot closer together. In fact, Casey is not now the highest in this region. Frankston now is. So that's another way of viewing the data, and it may be good for different purposes. What we're going to do now is demonstrate one of the most powerful features of the atlas, which is compare measure. We've already looked at the count, we've looked at the rate, but let's say we wanted to view them side by side. Compare measure allows you to choose any other map to display alongside the first. So I'm going to go back to notifications, show it, and this will throw them both together. So this is a good way of visualising two different things. It doesn't imply causation or anything like that. The data sets are independent, but you could be using those to demonstrate the number of services might be important for response services, meeting crisis services and situations, and the rate may be used for benchmarking how are these LGAs travelling, which one has the higher incidence in the population, are our efforts working with prevention and so on. Now what I'm going to do is go back to the single view, which is this button here. Click on Casey again, and now we're going to have a look at the fact sheet button. What this does is throws open the fact sheet relating to the priority area that we're in. So this will format all of the stats within this priority area, not just intimate partner violence, but everything in here. And they're quite long, as you'll see, it goes on for a number of pages. And everything's in here, the narratives, tables showing Casey, the region and the state average, all in there. In fact, we had to go down to about page 16 to find intimate partner violence, but it's all in there, the rate, the count, the whole lot. And we also notify the user of the local women's health service in the region in case you would like to follow up with the experts for your area. And that's how we, promote a statewide approach to women's health promotion. Now, interestingly, it's taken quite a few clicks to get to those fact sheets, so you might be pleased to know that if we go back home, and you can use the Atlas logo in the corner to get back, we've got a wonderful shortcut to the fact sheets now. It's a new feature. We can go in, start typing, or scroll down to your LGA. Whoop, went too far. Just bear with me here. And now you can get straight to all of those 6 fact sheets. And that's a much more efficient way if you already know the LGA you want and you want your fact sheets. Now I'm just going to quickly look at a couple of other things that you might be interested in. Let's look at a female-only indicator. I'll go into sexual and reproductive health and look at teenage birth, which is one of our more heavily used stats. Also, we have 6 time periods on this, so it's one of our most deep in terms of years. So this one, you'll see the male button is greyed out. You can't click on anything because there's nothing there, and there's no male bars in the chart either. Now, what I'm going to show here is we can use the time slider to go back through the years, and it appears that the colours have changed, but it's kind of hard to visualise. So what we're going to do is compare measure here, pick the exact same one. So we'll have 2 that appear identical, but now what I can do is just go to the latest year for this on this side, and we can instantly visualise the trend between those 6 time periods. So use compare measure to compare by time. The next example we're going to do is to compare something by sex. Now, we have to change both of these. What I'm going to go down to is gender equality, number of hours, percentage of people who've worked more than 15 hours per week. Let's show it for male. It's looking pretty green. Not many LGAs have males working more than 15 hours unpaid. Let's change this one to gender equality, unpaid domestic work. The indicator, and let's go for female this time. And as you can see, it's pretty virtually speaks to any audience, that one. It's just an example we often use. And now let's look at 2 completely different indicators, because you can also do this. Now, whether you should or could do this is entirely up to you, but bear in mind, you're going to have to interpret what you're seeing. So I'm going to use breast cancer, female, obviously. And now beside it, I'm going to put age group, women 65 years plus. And what I'm going to do is zoom into Metro, and it always zooms to the same zoom level. Now, those maps might appear to be visually quite similar, but again, it might be logical to say if you've got more older women, you're going to have higher rate of breast cancer, but the Atlas is not saying that. It's up to the user to interpret or decide what to make of that. There's no causation, they're completely different data sets. So if you're comparing things, just be aware you have to draw your own conclusions. And finally, there's only one other thing that I wanted to show you. I may have gone over time. This button here is where we have some national and statewide data sets that they can't be represented at the level of the Atlas. However, they may provide important context if you're reporting on a particular population or health priority area. You may be able to draw some narratives from those and other background. So that was all I wanted to say. Thank you. And I'm now going to pass over to Tom Hollands to tell you all about the technology behind the Atlas, and hopefully we don't lose you again. So I'm going to cross over and we'll get you to tell us whether, is that the one? Okay. If you could confirm in the chat that you're now standing behind the Atlas in a lovely photo of Tom. Let's just get in there. Yes, all good?
Great. Thank you, Jenny. Hello, everybody. My name is Tom Hollands. I work here at Spatial Vision, and I have the privilege of working closely with Women's Health on the Atlas project, as well as other projects. So today I'd like to take a step back and take you on a brief trip behind the Atlas and talk through a few aspects around the technology and the approach that was used to develop the application. So first, a bit of an overview of the design and build process and the principles we used to make sure women's health was at the centre of decision-making at all points. Then talk through the specific technology decisions that were made about the Atlas itself. And finally, some reflection on the application design with an emphasis on visualization and mapping and how they can be used to communicate and reveal themes. So the service we at Spatial Vision aim to provide as technology partners really centres on development of a collaborative relationship. We want to share our experience and ideas to create a solution with the client that achieves their desired vision and meets their needs. Women's health, of course, have unique and complex messages, and they need to be communicated with a large variety of stakeholders. And as we've seen, women's health are ambitious in their desire to use information technology to do this, as evidenced by their multiple IT products. So understanding this, the project was proposed and run following these principles. First of all, a collaborative design process focused on developing functional features from user requirements and delivery of a flexible solution that could continue to be updated in both content and function into the future. So at the beginning of this process, we ran a series of design workshops with Women's Health and their stakeholders, as Mischa mentioned, the reference group there, and we used these to identify user stories. So the premise for collecting these user stories as developers is that it lets us create clear business-oriented goals and map them directly onto software features. So these are plain language descriptions, so they're perfect for client transparency. Anybody can read them. And they're especially useful for testing because applications like the Atlas bring together a lot of different stakeholders, and it's very helpful to have a standard and clear way to describe exactly what the software needs to do. During the build process, Women's Health will physically use the application themselves during periods of testing and then assess whether these user stories have been addressed by the software functions themselves. So this approach is engineered to make sure that Women's Health is tied up really at every stage of the process, from design and build to deployment. And the goal here is to ensure that there are no surprises at the end. Women's Health will have been involved at every stage, so there will be nothing new. So next, I'll talk through a few of the more specific technology decisions that were made. So the solution itself is built using open source components. This includes a database, a reporting server, and the web application that is the Atlas itself. So open source is the key term here, as a contrast to commercial products. So the difference here is between off-the-shelf software that's been built for general use and custom open source software built for your own very particular uses. So commercial software, of course, is perfectly good in many cases, but it's usually better suited for prescribed processes or functions, and it can be difficult to customize if you have specific requirements. However, building a custom application using open source components gives developers the ability to extend and tailor features to meet those specific needs. Essentially, you're never building from nothing, and it is much simpler to extend functionality rather than engineer it from the bottom up. So this flexibility and adaptability is really what was valuable when considering the future needs of the Atlas, because it provides a base on which improvements can continue to be made over time, and indeed that's what we've done. So the app, that is the Atlas itself, is data-driven. What that means essentially is that it scales. So this is a great benefit to the Atlas because as the years go by, of course, the story will change. And the Atlas needs to grow to accommodate new and updated data sets that keep telling these stories. So the idea of a data-driven application, in an attempt to sum it up, is one in which all of the functional pieces are designed to work relative to a particular data structure. So once that data structure is defined, and this was an absolute key component of the design process and engagement with stakeholders, it can then be added to and built out into the future. What this translates to is that updating data is simply a matter of putting more information into the database, and the application will naturally scale. So finally, I'd like to talk about visualization, and in particular mapping. So as many people will be familiar, data in its raw form is a little bit hard to digest. It's particularly hard to extract high-level insights and stories without some way of viewing things more holistically. So visualization is one way in which we can do this, and it's basically a method of analysing data using abstract visual representations of that data. Classic examples are charts and things like that. There are many, many different sectors that employ visualization tools these days. Modern business, academia, journalism, and teaching all use a variety of visualization tools for their data because it's a very effective method of communicating big stories clearly. So as Mischa mentioned, the initial product that the Atlas was built from did not include maps, but as we will see, thematic mapping is a very, very effective way of examining these stories. So the idea of thematic mapping is essentially that it will take the location properties of data and visualize based not only on the data values themselves, but where they physically exist in the world. So the Atlas employs a simple but effective method of this thematic mapping by aggregating data indicators up to local government areas. So one of the effects of putting data on the map is that it ties it directly into the real world. And this is massively beneficial for users because location in the real world is something that is immediately and intrinsically relevant to everybody. And being able to perceive that on a map is a very powerful visualization technique. It ties people to their communities, and it really just provides instant context for users. So what that means is a user will look at the map and not only see what the data values are for a particular community or a particular area, but then also how that community compares to its peers, and moreover, how this patterns across the whole state. And perhaps even more importantly, it provides you with a common anchor point around which you can combine data sets by connecting data that occurs at the same location. Simply having tables of data next to each other doesn't necessarily make them compatible, but when you map them to the same geography, all of a sudden there's a commonality. And this brings me to intersectionality, which is a very important concept in the modern world. And thematic mapping methods like this are a way to analyze those various intersectionalities with respect to their location. And indeed, it's one of the key benefits of the Atlas itself, which combines a whole variety of demographic, health, and legal data sets, as we've seen. And they all use the same map, so uncovering the relationships that may have remained hidden behind there at your own peril is one of the really powerful things that the Atlas can do. So to summarize the technological approach we used to develop the Atlas, it was a collaborative design process that was really focused on aligning application features directly with stakeholder needs. It's an open source data-driven web application, and this is a choice we made to support flexible content and functional updates as the Atlas grows and matures. And a communication focused on data visualization, incorporating both thematic mapping and charts to provide the user with a curated story of the gender divide across Victoria. So that's it for me for the brief look behind the Atlas. I'll now hand it back over to Jenny.
Thank you, Tom. I'm just going to go over a couple of key learnings. One of my roles is to curate the content for the Atlas and to liaise with data suppliers. So we've learned quite a bit in the process, and I'll just share a few things about that with you. To date, with the Atlas now 4 years old, we have 12,000 users to date, about a quarter of whom are returning users. The most accessed material we've looked back through is in the violence against women section, family violence and perceptions of safety when walking alone at night in the local area. Within section reproductive health, teenage birth and STIs, in particular chlamydia, and in mental health, anxiety and depression, and self-harm hospitalisation for male and female, which is a fairly new one that we've added. So over the years, we've had a lot of requests to do a lot of things with the platform, but what we've tried to do is keep it simple and easy to use and avoid the temptation to add too many bells and whistles. This has proven to be good because it means that it's opening up other sectors and users. We don't need a lot of training to actually use the platform. It's very important to keep it updated. The data sets all come in at different times, which can be difficult to coordinate. What we try and do is batch the information into tranches, update it twice a year, and we've chosen to align those with the release of the crime data, which comes out twice a year and is very on a strict schedule that we can align with. So that everything goes on those dates, which means we update in April and we update in October. We've tried to make it flexible so that users can control how they choose to visualise the data. Because we don't know what the needs will be from one day to the next. So avoiding a fixed display gives a lot more uses for the data. Quality control is vital because everyone needs to trust this information, and a mistake once it's in there is much harder to get out and causes great agony. So we have to make sure it's correct before it goes in and liaise with the suppliers. And we've also provided context for the data, so we don't just hit you with numbers and maps. We also provide narratives, explain why it's important, where it came from, and anything you may need to know to help you interpret the data. As far as collaboration, we've not always had the expertise that we've needed. For example, we're not epidemiologists. We don't know the technology that visualises data. So we've brought in the experts as required, listen to and trust those experts. We've also listened to our users and stakeholders, and most of the development we've done and new features, things like the time slider, compare, measure, and the shortcuts to the fact sheets have all come from our stakeholders who've said, we need these things, please give us these things to make our life easier. We've had to establish processes for workflow management, data processing and quality control. How did you get this data? Prove how you processed it. Where did it come from? Who did you talk to? You know, there's a lot of information about those data sets. And we've also tried to engage data suppliers in the process, bearing in mind there's nothing to map if they don't provide the data to us. So we're grateful to them. We need to have good relationships with them. We give them the opportunity to have input to the narratives and also to have preview the data so they see the story first before we release it to the unsuspecting public. Some of the challenges that remain with us, well, an early one, as Mischa mentioned, was translating so many different user needs and stories into one design brief. We acknowledge there are limitations of what we can do in representing the data in this way. So populations such as migrant women, women with disabilities, Aboriginal women, young women, older women. It's very hard to get the data that can represent that and also be disaggregated by LGA. We acknowledge that we're mapping a gender binary female-male situation and we just don't have the availability of data for other identities to have another tab alongside female and male. We are aware of the need to represent data for those groups, and if we may look at that over time, what we can do. Ongoing resourcing and sustainability is an ongoing issue. As it was, we had a couple of one-off grants from time to time. We've had funding from time to time from the state government. It's a huge human resources burden to curate, liaise and deal with the data coming in, to organise it and do the processing. We pay for our updates. Anytime someone has to do something, there's a cost involved, either in time or, you know, a fee for the updates. So obviously as we add more data, we have to maintain it more often and the burden increases. So we're just saying the bigger it gets, the more investment is required. Okay, and that's really that from me. I'd now like to hand over to Django Love, who's going to talk about impacts.
Great, thank you, Jenny. I'm going to focus on a couple of case studies now, just to show you how the Atlas has been used to date and the impact of this. So, for example, the Atlas is specifically at the moment used by local council, government workers and women's health organisations. I'll give you the example now of how the Atlas has been used in developing the health and wellbeing plans of councils, which are developed every 4 years. One example is Macedon Ranges Council, for example. Throughout their plan, they have referenced, they've used specific sex disaggregated data and the gender analysis from the Atlas throughout their plan to specifically highlight those key priority areas that need action to better support women's health. For example, in family violence or sexual reproductive health. And again, and another example is through women's health organisations, such as in this example, Women's Health in the North, using the Atlas to be able to advocate to their council to demonstrate that sexual reproductive health, that there's a number of key concerns within the North, and that this needs to be addressed, and therefore the relevant Northern local council included sexual reproductive health as a priority area in their plan. The Atlas is also commonly used by those undertaking training, particularly because it's a visualisation tool. It allows an excellent tool to really highlight particular gender inequalities, and it always speaks to people if we're able to demonstrate that in their particular LGA. So, for example, it's currently has been and is being used by workers working in schools on respectful relationships education, where they need, and this is an education program around the prevention of violence against women, where it's really important to be able to go into the school and ensure that the whole of school is on board in terms of understanding gender equality and why it's important to prevent violence before it happens. So the Atlas has been a tool that, again, shows that picture in their region to be able to start having those conversations in schools. And you can see on the slides a couple of quotes from those who have who regularly use the Atlas and why it's important for them. Another good example is we're currently partnering with the Geography Teachers Association of Victoria, and what we've done here is we have actually developed with the Geography Teachers Association a number of specific lesson plans that can be taught in geography classes in schools. So from Women's Health Victoria's perspective, this is a way to ensure that key information on gender equality is mainstreamed into everyday learning. And from Geography Teachers' perspective, it's a useful resource to highlight actual issues that are relevant in their specific LGA to engage students. And they've also noted that it's easy to use, and it's also a tool that students can access from home if they're going to, for example, link it to assignments that students need to work on. And again, linking back to the respectful relationship, how this can support the respectful relationship work that's happening in schools. This is a way to integrate gender equality within mainstream teaching subjects outside of the usual health stream, and again aligning with that whole of school approach to promoting gender equality throughout the school. And there's potential to expand this model into other subjects, whether it be such as maths or health, again to have that broader reach within schools. So that's just a quick sample of, I guess, how it is currently being used. In terms of our next steps, we regularly do 6-month updates on the data to make sure that you're getting up-to-date data in the Atlas. We do provide support and updates, and can
provide some more training on the atlas. So if you do have any questions after this presentation, please do get in touch. We're looking at how the atlas may be beneficial to beyond, I guess, our existing users, which is particularly, as we mentioned, local council and community health organisations. And as Jenny mentioned, there's the atlas to maintain does take a number of resources, and particularly we want to do some expansion, and again there is a sustainability question there. And finally, the key things that are on our agenda for next steps is a formal evaluation. What we're hoping that this will do is really unpack those, really help us understand how the atlas has been used to date, and again how we can improve it going forward. Potentially looking at how the atlas could be rolled out beyond Victoria, either in its current form or potentially to support a specific area such as family violence, for example. We would be interested in partnering with, say, an academic institute to be able to provide further analysis on some of that data, so we can actually provide, I guess, answer some of those questions about what this data means. And again, we are interested in expanding into new priority areas such as chronic disease, and currently the map is focused on health promotion data, but we're particularly interested, but there could be questions about could this be used to map services as well as from a health promotion perspective, such as, again, potentially family violence services and the number of people accessing those. Particularly at the moment, we are looking for funding. I guess our priorities are around the evaluation and also expanding on the Geography Teachers Project to create some more lesson plans and to pilot them in schools. I am going to wrap up now and hand over to Ken to close the webinar. So thank you for your time so far.
Terrific. Thank you very much, Django. This now concludes the formal part of our presentation. As indicated, we will be sending out a short survey. We'd certainly love your contribution to. We'd love to know what you thought about the content, what you've learned, and certainly any information you'd like to know more about, we'd be more than happy to respond to you with. Secondly, we will take all of the questions raised during the session and arrange to consolidate those and share those with the group. Certainly, if there were any discrete or direct questions with contact details, we will arrange to respond to those individuals or organisations in a more direct sense. And of course, we have recorded the webinar, so we'll arrange to disseminate that to everyone that joined us today to view and or share in your own time. So in terms of next steps, again, if there are any questions or if there's anything that you've seen or heard today that you'd like to know a bit more about, please feel free to contact Jenny Ward from Women's Health Victoria or myself at Spatial Vision, and we'll endeavour to assist you in any way we can. But I'd otherwise like to take the opportunity really to thank our speakers today. So Mischa, Jenny, Django and Tom, thank you very much for your insights and time. I'd like to acknowledge Amelia Lazarus and Lauren Ferris for their hard work and efforts behind the scenes making this event possible. And of course to everyone that has supported Women's Health Victoria and continue to invest in the development of this atlas, this very important resource. And finally, just a quick thank you to all of you for joining us today. We really hope that you found the information of value, and we'd like to wish you all a great afternoon and look forward to reconnecting in due course. Thank you so much.